Hello everyone, my name is Joseph Arayathel. I'm currently enrolled in the Psychiatric Mental Health Nurse Practitioner program at Eastern Kentucky University. Thank you for joining me today. As part of our NSC 892 course, I'll be presenting my quality improvement project in this video. You can see the poster on the screen, and the title of the project is Motivational Interviewing to Improve Medication Adherence in Adults with Severe Mental Illness in Rural Outpatient Clinics. Background and significance of this project. Medication non-adherence among individuals with severe mental illness such as schizophrenia, schizoaffective disorder, and bipolar disorder is a persistent clinical challenge. Non-adherence can cause relapse, emergency unit visits, rehospitalization, suicidal behavior, and an overall increased burden on the healthcare system. In rural areas in particular, this problem is compounded by limited access to care, provider shortages, poor transportation, and stigma surrounding mental illness. These barriers make it difficult for the individual to consistently follow prescribed treatment plans. As a result, improving medication adherence in rural psychiatric settings is both a clinical and a public health priority. Theoretical framework. To guide this intervention, the project draws upon the health belief model HBM, which explains health behavior through the lens of individual beliefs. It emphasizes how a person's perception of their illness and belief versus barriers of treatment shape the likelihood of adhering to the care. Because this project focuses on changing patient beliefs and motivation towards medication adherence, an intervention that supports belief change and empowerment is essential. One such intervention is motivational interviewing, which aligns well with the health belief model. While HBM outlines psychological components of change, motivational interviewing provides a conversational method to influence those beliefs. It supports patients in exploring their readiness for change, enhancing perceived benefits, and overcoming perceived barriers by tapping into personal values and goals. MI respects the autonomy of patient and is particularly valuable for individuals who have experienced stigma, trauma, or a loss of trust in healthcare systems. This collaborative approach is especially important in rural populations where trust and autonomy are key. So, the proposed intervention is motivational interviewing, which is a brief, structured, patient-centered communication strategy that encourages self-motivated behavior change. In this project, adults diagnosed with schizophrenia, schizoaffective disorder, and bipolar disorder who have demonstrated medication non-adherence will participate in 8 weekly 30 minutes MI sessions in the clinic. This session will be conducted by trained staff using motivational interviewing principles such as reflective listening, affirming patient strength, and gently guiding them towards making health promoting decisions. Sessions will include visual aids, teach back techniques, and written summaries. Booster sessions and written and follow-up calls will support patients through challenges in adherence. All interaction will be documented in the electronic medical record to ensure communication among the care team and continuity of care. Supporting evidence. This intervention is grounded in research from 3 key studies. Ayarkush and Babaolo in 2023 conducted a systematic review of MI in psychiatric settings, concluding that MI improves medication adherence and therapeutic alliance, especially in patients with insight-related challenges. Kuhn-Kush Hash et al. Performed a quasi-experimental study in individuals with schizophrenia, finding that MI significantly improved both insight and treatment compliance over a structured intervention period. Similarly, Hong et al. In 2021 examined the combination of MI and cognitive behavioral therapy and found sustained improvement in medication adherence at both 3 and 6 months post intervention. These studies support motivational interviewing practical utility in real world psychiatric settings and reinforce its adaptability in outpatient and rural environments. Implementation plan. This project follows Johns Hopkins evidence-based practice model for translating research into practice. First, patient identification. Adults aged 18 and older with schizophrenia, schizoaffective disorder, or bipolar disorder who have documented non-adherence in the past 3 months will be selected. Staff training. Clinical staff will receive a 2-week structured training in MI, including role play, feedback, and scripting. Intervention delivery. Each patient will attend 8 MI sessions. Sessions will be personalized using motivational prompt, teach back, and visual communication tools to accommodate cognitive differences. Follow-up and support. After the main session, booster sessions and follow-up phone calls will be offered to reinforce adherence behavior and support problem solving. EMR integration. Staff will document each session on patient's electronic record, ensuring multidisciplinary access and continuity. Outcome measures. We will evaluate success of intervention using both primary and secondary outcomes. Primary outcomes will be medication adherence will be assessed using pharmacy refill data, pill counts, and MARS medication adherence rating scale, a validated 10-item questionnaire designed for psychiatric patients to capture both behavior and attitude toward medication. Secondary outcome. PANSS, Positive and Negative Symptom Scale, used to assess symptom severity in schizophrenia. PHQ-9, another tool which is widely used to assess and track depression severity. We will also look at 3-month hospitalization rate to gauge overall treatment effectiveness and relapse prevention. And finally, patient satisfaction, measured through interviews, exploring perception and usefulness and support. These tools are practical, accessible, and highly relevant to both patients and clinical in rural settings. Timeline. Week 1 and 2 will be for staff training. Week 3, patient screening and recruitment. Patient 4 to 11 is the key sessions where patients are given motivation interviewing sessions 30 minutes every week. Week 12, collection and adherence on symptom data, patient feedback. Week 13, team debrief and data analysis. Week 14, report writing and dissemination to clinical stakeholders. Conclusion. This project presents a feasible evidence-based strategy to address the pressing challenge of medication non-adherence in adults with severe mental illness. By implementing motivation interviewing in rural outpatient settings, we can strengthen therapeutic engagement, empower patient-driven decision-making, and ultimately improve patient outcomes. As a future psychiatric nurse practitioner, I'm committed to integrating person-centered, evidence-based strategies like this into clinical practice, particularly in underserved communities. Thank you again for your time and attention. I look forward to your questions and feedback. Closing note, all supporting references are listed on the poster. The evidence shared reflects current research in psychiatric nursing and behavioral health.